Hello, this is Jessica Hoy, and this is chapter 4, I believe, of pneumonia. Pneumonia. And this is where we're going to start talking about planning. We've talked about different categories, different classifications, different causes. We've talked about assessment. We've talked about diagnoses. So now we're on to our plan. Let me share my screen so you can see what I'm talking about. So planning, we have some very clear goals with these people, but they have a few different avenues. So we want them to have clear breath sounds because clear breath sounds means that there's not anything in the way of that oxygenation process. We want them to have normal breathing patterns, which means they're not working to breathe, hard to breathe. No signs of hypoxia. We want to have normal chest x-rays, which is that imaging so that we can see there's nothing going on in there. We want the white blood cell counts to normalize and an absence of complications. Part of our planning when we're doing this to get to these goals is we're going to be starting empiric antibiotics. So empiric antibiotics are where we are actually starting treatment before there's any definitive diagnosis. So we'll start them on a broad spectrum antibiotic before we even really know if it's bacterial, fungal, viral, whatever. And there are times where we'll do this sort of broad spectrum antibiotic therapy depending upon risk factors. Do we have early or late onset? Like where are they at? How long has this been going on? What's their presentation? Are they super duper sick and blue? Are they walking, talking, and complaining of a cough? Underlying medical conditions are people with long-term lung infections, immunosuppressant therapy, cancer therapy. We are going to be looking at those things differently than maybe we would like your average normal human being. Hemodynamic stability, if they are hemodynamically unstable, that could definitely indicate that they are having a systemic reaction, which pneumonia often leads to sepsis if it's left unchecked and untreated. So we would rather throw all the antibiotics that we can on that to prevent sepsis than letting it hang out. And we determine the empiric antibiotic therapy by the most likely causative organism. We're going to talk about more of this on slide 33, but I wanted to when you are developing your plan, you should be planning on having some empiric antibiotic therapy. Should be within your realm of understanding. Helps you get to. So for health promotion, so there are things that we need to do interdisciplinary. That empiric antibiotic therapy is an interdisciplinary thing. It's something that we work with medicine on. Independently, we can do health promotion. So we're going to be teaching hygiene, the importance of proper nutrition, the importance of adequate rest, and of getting some regular exercise. How to properly cough. Please don't cough into your hand. Please cough and sneeze into your elbow, because all of a sudden you're coughing into your hand, and then you grab a pen, and then you share your pen with somebody else, and then all of a sudden they've got whatever you've coughed all over your hand because it's on your pen. Avoiding cigarette smoke, if at all possible, because cigarette smoke, both primary and secondary, is going to be irritating those lungs. Avoiding exposure to upper respiratory infections. These people should be wearing a mask, not only because they are going to be protecting other people, but they're also protecting themselves from picking up another URI. Identifying any risk factors, those are identified in table 27.1. We mentioned those earlier. And then influenza and pneumococcal vaccines are health promotion things. So not only getting vaccinated for the influenza strains it's a combination immunization that's given every fall, but the pneumococcal vaccines that are listed in table 27.5 are also very important. Those aren't given necessarily every year, depending upon what they're doing. There's a couple different ones out there, and those are specific to other types of bacterial pneumonia, so they don't have to be updated as much as the viral influenza. So when we are taking care of these clients in acute care, so these patients are super sick, they've been hospitalized, we are going to be monitoring assessment parameters, providing treatments, and monitoring responses. So we're going to be collaborating with a lot of different people. We're going to be collaborating with respiratory therapy, with physical therapy, and then, like I had mentioned when we were talking about empiric antibiotics, with medicine as well. We will collect specimens and send them down to the lab so that we can get as good a jump on things as possible. And then we're going to be administering antibiotics. Please note that order. We are going to be collecting any specimens. So if you've got somebody coming in with a productive cough and they look a little pneumonia-ish, just figure you're going to need to collect a sputum and then start your antibiotics. In addition, we're going to be working on oxygenation. So we're going to be applying perhaps some supplemental oxygen for oxygenation rates that are below their normal range. We're going to be providing hydration, nutrition. Sometimes hydration and nutrition can come in the same package. We'll maybe look at getting them as many milkshakes as they can tolerate, because then they can sip a little nutrition and a little fluids in between, and then take a break. We're going to be teaching breathing exercises. We're going to be moving these people. They don't want to move. We're going to move them. So we're going to be moving them from the chair to the bed, from the chair, and vice versa, perhaps taking short walks in the hallway. The more we can get them moving, the more we can open up this chest cavity, the more we can have these core muscles help with breathing, and the faster we can get that pneumonia out of the system. And then we'll also work on positioning. There are times where positioning is really important. We probably won't want to have this person lying flat on their back because of the shape of the lung, and because that actually will have the fluids shift to the biggest body surface area, or the biggest surface area of the lung. Instead, we'll have the head of the bell tilted up. They may not even be able to tolerate laying flat, depending upon how severe their pneumonia is. And so we'll work with them on appropriate positioning. We're also going to work on preventing aspiration pneumonia. So we are going to have that head of bed at 30 degrees and have them sitting up at all meals. We're going to be assisting with eating, drinking, and taking meds as needed. We'll be assessing for gag reflex before we give them anything to eat or drink. We will look for and monitor reflux. We'll also look for and monitor gastric residuals in their NG tubes. It's part of our head to toe assessment for a person who has a nasogastric tube, whether or even a PEG tube. We want to make sure that everything's getting digested and moving through the GI system. So we measure those gastric residuals. We'll be doing early mobilization. We're coughing and deep breathing. We're going to be using incentive spirometry. Remember that incentive spirometry is a vacuum game. So that is where the patient is not blowing out. That's the PEFR test. Incentive spirometry is when they are sucking in and they are on vacuum, and they are seeing how much they can move that disc by sucking in. It causes them to cough. They hate coughing, but it causes them to cough. And coughing is good because coughing moves the mucus around for as much as it hurts. And I know that it hurts, but we need to do it because we can move the mucus around and we can get your oxygenation better. And then we're going to be looking at twice daily oral hygiene. Those patients who have an ET tube may be getting more than that, should be getting more than that. Current evidence-based practice indicates oral hygiene every 2 hours. And lastly, but not leastly, while people are in the hospital, we are going to be using medical asepsis, and we're going to be doing infection control, where we are using excellent hand hygiene. We are also going to be doing sterile technique if we have to do any sort of tracheal suction. Y'all learned how to do that in your skills lab in term 1. We're going to be carefully handling any respiratory equipment. We're going to be avoiding any inappropriate antibiotic use. Depending, to just follow along with this particular slide, depending upon what their agent is that caused the pneumonia, they also may be in precautions. So they may be in droplet precautions. because their infective agent is influenza. And we don't want to accidentally be spreading influenza all throughout the ward. So we will be putting them in precautions sometimes to be able to isolate that particular organism to that particular room and that particular client. So I'm going to stop sharing my screen here. I'm going to stop recording as well. Again, I like to do little tidbits. So tidbit number 5 will be, I believe, the last tidbit. And look for that recording coming up next. We'll get out of acute care nursing and we'll get into ambulatory care and some other